heart failure is not the new disease, but the new concepts are being emerging every year. Because the heart failure patient was documented 3,500 years ago in the mummy of Nairobi of Egypt that documented the evidence of heart failure in the mummy. And the symptom of heart failure was vividly described by the Anna, the daughter of Alexis, Emperor Alexis. About 1,000 years before Christ, she described the symptom of her father in the biography. That symptoms are exactly similar that is documented in the recent texts of cardiology. So heart failure is every day, the concept is being changing, but the disease is not the changing. Disease remain as it is. Honorable chairpersons, distinguished audience, first of all, I express my thankful gratitude to the organizer who gave me the opportunity to talk on management of heart failure with reduced ejection fraction. In my talk, in 10 minutes, I will try to limit the talk to the diagnosis and treatment of the heart failure, because diagnosis is the part of management. If we look at the Professor Adut Chaudhuri already mentioned that the 6.4 million people are suffering from heart failure in the globe. About 2 million people are recruited in every year as heart failure, and 1 to 2% population of the adult population in the western part as well as the neighboring country like India suffers from heart failure. So on that context, more than 2 million people is present in our country suffering from heart failure. So it is it is really a challenging burden for the nation. And the simplest definition of the heart failure is the condition in which the heart fails to discharge its contents adequately. If you look at this pathophysiologic slide, this is the basic slide. The understanding of this slide is the key for the management strategy of the heart failure. If you look at the upper panel is the sympathetic panel that comes to take over to compensate the heart failure symptoms, RAS system and natriuretic peptide system. These three systems comes to combat the heart failure, and they are the beneficial at the initial phase. But later on, their continuous activities becomes detrimental, and countering these three parts is important in the management of the heart failure. So this pathophysiologic change we have to keep in mind in the management of the heart failure. Staging of the heart failure, all of you know, I am not going to discuss in detail, and heart failure classification which we are following for the management purpose. Already Professor Adut Chaudhuri discussed the management of the heart failure with preserved ejection fraction, and another group is the reduced ejection fraction. In between is the heart failure with mid-range ejection fraction. Recently the nomenclature has been changed to mildly reduced ejection fraction. For practical purpose, management of this group should be included in the group of heart failure with preserved ejection fraction. When we want to diagnose a case of heart failure, we have to suspect. The level of suspicion is very important for the making the diagnosis of the heart failure. And this suspicion is on the basis of the clinical history. If a patient has got the history of coronary artery disease, history of arterial hypertension, exposition of the cardiotoxic drug and radiation like cancer chemotherapies, if the patient takes diuretics therapy before coming to the physician, if there is any history of orthopnea, paroxysmal nocturnal dyspnea, or any sign that suggests heart failure, or if there is any ECG evidence of any cardiac abnormality like left ventricular hypertrophy, enlargement, any form of arrhythmia, evidence of myocardial infarction, etc. Considering these three important parameters, we have to proceed to make the diagnosis. If one or two of these are present, the suspicion of the heart failure is strong, and then the patient should be evaluated by the peptides. NT-proBNP is routinely practiced in our country, or we can go for the evaluation by the echocardiography. We can go in two ways, direct echocardiography, or if the NT-proBNP is elevated, then we can subject the patient for the echocardiographic evaluation. So we will make the diagnosis. Without echocardiographic abnormality or normal peptides, diagnosis of heart failure is unlikely. Many treatment, what is the treatment objective of the heart failure? That is very important. That we have to understand. We need to improve the prognosis. Prognosis means improve the motility. Second is the morbidity benefit. Third, we have to go for the prevention of the development of the heart failure, or if the patient developed heart failure, we have to prevent the deterioration of the heart failure. And management of the heart failure includes non-pharmacological approach, pharmacological approach, and some device therapy that is emerging as the important therapy for the heart failure management. Among the non-pharmacologic therapy, education of the patient, I think, is the most important part of the management of the heart failure. Without educating the patient, we cannot adequately control or prevent the heart failure. So every patient should be educated properly. Then is the sodium restriction. All of you know, I am not going to discuss in detail. The salt restriction should be in between 2 to 2.3 grams. That is recommended by different guidelines. Though the past guideline recommended the salt intake up to 3 to 4 grams, that is reduced to 2 to 2.3. Cessation of the other risk factors like smoking, alcohol, etc. And we have to encourage the regular, moderate aerobic exercise. So, vaccination is another important issue in the management of the heart failure. Especially the elderly population should go for the yearly vaccination for the influenza and 5 years interval vaccination for the pneumococcal infection. So guideline recommended management is discussed in this fashion. I am not going to discuss in detail. Among the pharmacological therapy, the past therapy has been changed in the recent years. So I am focusing on some important drug that was the key management part in past heart failure management. That is the diuretics. So diuretics was strongly recommended, but now it is not recommended in every patient if there is no evidence of the volume overload. Ivabradine is regularly practiced in some part, but ivabradine is not recommended routine use in heart failure patient. It is recommended to use on the top of adequate dose of beta blocker. If that fails to control the heart rate below 70, only then we will add ivabradine in this situation. Digoxin, statins, already Dr. Abdul mentioned like that. Statin only indicated when the patient had disease and statin has got some preventive role. Otherwise, it is not recommended. And digoxin is class 2A indication. This is the flow chart for the management recommended by the ES in 2002-21. This is the latest recommendation for the management depending on 4 pillars. One is the ACE inhibitor or RNA, beta blocker, MRA, and SGLT2 inhibitor. These 4 pillars are the mainstay for the management of the heart failure. On the top of this management, we can use diuretics, we can go for the use of other agents like device therapy and so on, and this chart clearly defines the indication status. The color indicates the class 1, class 2B, like that. So these are the sequence of the management of the heart failure. So these are the trials. Paradigm heart failure trial is the one of the important trial that recommended the use of ARNI, and its superiority was proved in 2014 by over the AC inhibitors. This is the sacubitril and acute heart failure in pioneer heart failure. That is the acute setting of the heart failure. The ARNI use gives the definite benefit on heart failure management. So, as I am at the end of time, I am going fast. Dapagliflozin is recently recommended in 2021 because it gives the definite beneficial effect in the management of the heart failure, and it is recommended in 2021. So, dear audience, the changing therapeutic option is on the basis of the evidence, and this evidence is coming by different trials. So what is new today will be newer tomorrow, and what is updated today will be revised in future. So innovation is an endless procedure, and I invite the younger generation in the cardiovascular field to have the visionary approach to be a part of any innovation and discovery for the management of the heart failure. Thank you everyone for patient hearing.